Obviously following in the theme of closing the gap, I welcome Professor Alan Cass, who's the Director of the Menzies School of Health Research. As most of us are aware, Menzies has a long-term commitment to improving Indigenous health and wellbeing and addressing the high priority health problems of communities in Northern Australia. Alan trained as a nephrologist at Sydney Uni and Royal Prince Alfred and has pursued a research career focused on the prevention and management of chronic disease and Indigenous health. But what you may not know about Alan is that he invented a new crepe, which he retails at the Parrot night markets: bacon, egg, cheese and mango. I'm not sure how well it sells or whether this is his new business, but he's very proud of it. Thank you, Alan.
I don't actually retail the crepe, but Ken of Ken's Crepes makes it for me, perhaps under sufferance. I certainly enjoy it. Well, I'm not sure that anyone else gets that crepe made. Today I do want to talk about kidney disease and the importance of listening to the voices of Aboriginal and Torres Strait Islander people affected by kidney disease. Yes, I'm a kidney specialist, but I think kidney disease is unique. It is an incredibly complex chronic disease, one that is affected and shaped by the same social determinants others have been talking about. But the way in which it is unique is that the way in which we have provided care, Aboriginal people have been required to leave their community, their country, has caused massive disruptions to families. There are many related conditions that cause morbidity and affect our quality of life, but in general, you can live in a community with your diabetes, with your heart disease, with your trachoma, but through the way our health system has operated, when you have developed severe kidney disease, and 1 in 40 Aboriginal adults in the Northern Territory now survive on maintenance haemodialysis. 1 in 40. In that situation, it causes massive, permanent disruption for individuals, families and communities. So I think that's why it's so critical that we have a whole-of-system approach and that we engage, listen deeply to what people and their families and communities say and challenge the way in which we provide services and think about responses. People have been talking about these issues over the last day and a half. The interrelated chronic vascular metabolic diseases and cancer, early mortality due to these is what makes up the vast bulk of the gap in life expectancy. Kidney disease is a remarkably increased burden amongst Indigenous Australians, and particularly more so amongst women than men, something that we poorly understand thus far. It impacts at an early age. So your run-of-the-mill kidney specialist working in Sydney or Melbourne or Brisbane or wherever will be increasingly treating an elderly population. Now, I can remember treating 90-year-olds on dialysis in major teaching hospitals in Sydney. The average age of new patients having dialysis treatment is now in the high 60s of new patients. This is clearly, obviously, not the experience amongst Aboriginal and Torres Strait Islander Australians, where we're talking about young, middle-aged men and women, and where that excess burden is at a time of maximal productivity and engagement in family and community. I appreciated the talk of the Minister this morning and always want to acknowledge where there is progress being made in terms of closing the gap. Unfortunately, at the moment, I'm a glass half empty person, not a glass half full person. and I'm going to present now briefly evidence why I think, unless we do something fundamentally different about the prevention of chronic disease, the gap in life expectancy will grow over the next generation, not continue to narrow. Why do I think that? The critical things, I think, are the rapid increase in overweight and obesity amongst young people. Now, this is a global phenomenon, but is particularly prominent amongst Indigenous populations. And of course, what's intriguing on this slide is that the most rapid rate of increase is in here poorest countries, so that, as one might not surprise us, high income, is now virtually that with the lowest prevalence of the population of overweight children. But there you can see internationally that it's the lower income and lower medium middle income that are increasing at the most rapid rate. But what I'm interested in particularly is that we see a rapid increase in elevated blood pressure, obesity and type 2 diabetes in young amongst Indigenous populations in Australia, New Zealand, Canada and the United States. Many of you will have been aware of the case report, I think in the Lancet a few years ago, of a 5-year-old Torres Strait Islander girl diagnosed with type 2, what we would normally call adult onset diabetes. I can assure you that if that 5-year-old, and I'll show the evidence why I can assure you of this, survives well into adulthood and doesn't, unfortunately, die early of myocardial infarction or stroke, she will be on dialysis before she's 40. What concerns me is that and the rapid increase in the rates of youth onset of type 2 diabetes and diabetes in pregnancy. And it is amongst these people that the risk of renal damage, both development of chronic kidney disease and severe kidney disease requiring dialysis or a transplant, is so much more prominent. So compared to youth type 1 diabetes, or obviously, age, sex and whatever controls, the risk of developing significant renal failure is massively elevated. And here is some cohort longitudinal follow-up. Again, clearly the numbers fall when you get out to 15, 20, whatever years, but showing that incredibly clear divergence amongst the youth onset type 2 diabetes cohort in terms of developing significant renal disease. So unless we do something fundamentally different, and a health system has a responsibility, but a whole of government and community response, I think we are doomed to continue to make the same mistakes in opening more dialysis units across remote Australia and providing more and more complex, costly treatments to try and cope with things after people have got to the cliff. What drives the burden of disease? Quite clearly, I believe this is driven by socioeconomic disadvantage and poverty, where the strongest association, this is not causative, but I can think of and postulate many causative pathways, is that between markers of disadvantage and poverty in Indigenous communities with the burden of kidney disease. I'm trained as a doctor. Many of us here are we're medical professionals predominantly. And so although we need to provide the evidence and advocate for particular responses to address housing, employment, education, and I'll talk about some of those, at the same time I think there are important things that need to be done within the health system. What is the evidence about kidney disease? So it is clear that low birth weight and intrauterine conditions are strongly related to the risk of developing progressive kidney disease as an adult. And here in a systematic review, looking at cohorts across the globe, they could see about a 75% increased risk in adulthood of people developing significant kidney disease who are born of low birth weight. Here, I think issues about nutrition and food security are fundamentally important in terms of what we need to address about the burden of chronic disease. A photo I took at a remote community of a salad pack in their community store, poor quality food at high cost, at the same time in Coles in whichever capital city you could see, pristine heads of lettuce that were available. And we know the evidence. I can't cite all of the evidence of a food basket costing 60% more in remote communities than in urban settings, and of the issues of what happens when you're making decisions about feeding a family, for example, and you're on low income. This, of course, gives us pointers to interventions that we might need to undertake in partnership with community. Here, the Shop at Rick study with 20 communities across the Northern Territory implemented a price discount on water, low sugar soft drinks, fruit and vegetables, and showed an increase in the purchase of fruit and vegetables across those communities when that, as would be one plank of a strategy, was implemented. Increasingly, we're very concerned that in remote areas, people with early chronic kidney disease who should be able to be maintained healthy on effective management of blood pressure and diabetes, for example, in communities for many years, are very rapidly progressing to have severe illness, and then in an emergency situation coming to Alice Springs-based Hospital or Darwin Hospital or Cairns or Townsville, needing dialysis to keep them alive. And something that we need a high priority is that intersection between the recurrent burden of infection and progression and development of chronic vascular and metabolic disease. Increasing evidence shows that there is very rapid progression towards dialysis, and that there is again potential for prevention, education and primary care-based strategies to address that intersection between infection and progression of kidney disease. We are working with Aboriginal health services across the Territory, and we know there are a large number of people at risk of or with chronic kidney disease and related metabolic and vascular diseases, and there's strong awareness about these conditions in Aboriginal primary care and rural and remote settings, but that causes incredible challenges to the system in terms of how we ensure people are screened, identified, given best practice treatment, that we maintain contact with these patients and try to achieve the best health outcomes. And there are still gaps. I'm not saying, in fact, some of the evidence suggests that Aboriginal community-controlled services are as good as or better than other services across the country, but there's more that we need to do across the country to address this heavy burden of illness. I want to, in the last part of this talk about those patterns of healthcare delivery and the voice of Aboriginal people. And here, perhaps I want to challenge some assumptions. These are assumptions held by my community, for example, those of kidney specialists. But we commonly talk, for example, about Indigenous Australians being heavy, high users of hospital services, that 2.3 times more likely than other Australians to be hospitalised. But almost all of this is due to high rates of hospitalisation for haemodialysis, for end-stage kidney disease. And this is predominantly short admissions for a dialysis session, which happen 3 times a week for people to stay alive. But what it talks to is a fundamentally different pattern of health service delivery. That where for non-Indigenous Australians with severe kidney disease, we are much more effective in a community-based model of service provision, either through giving people more transplants or training more people on peritoneal dialysis or to manage their own haemodialysis at home. The vast, vast, vast majority of Aboriginal and Torres Strait Islander patients receive their ongoing care in hospital at high cost, and I'll talk about what they tell us about this pattern of healthcare delivery. And this again just shows, perhaps like Tom Karma's map, a map where we looked at 6 years of patients commencing treatment for severe kidney disease, where the non-Indigenous patients were. At the time we did this research, the hospital and national data suggested Aboriginal people were in the same place. Why? Because the way they characterised where people were from was to ask them their postcode when they started treatment, by which time someone had moved from the Kimberley to Perth, or someone had moved from Lajamanu to Darwin, or someone had moved from Kiwakara to Alice Springs. So their postcode was the postcode of Perth, or Darwin, or Cairns, or Townsville. So we asked people where they had come from and got this clear picture. So this was the first clear representation of where people were actually from who had kidney disease, and began to bring out and illuminate those issues of getting access to treatment where people wanted it. Then I'd like to finish by talking about 20 years of qualitative research, talking with Aboriginal people about their experiences of care, what matters to them, which I think is critically important. It's been some of the most enjoyable and fundamentally important research that I've been involved in. Some of it has involved me as researcher and being researched, and I'll talk about this in the first example. Here, back in 2001, because we as the kidney specialists, nurses and educators and patients and their families were concerned in Darwin that we felt we were communicating poorly about critical issues around kidney disease, we undertook some participatory action research where patients and community members were full members of the team with us, where we filmed interactions between patients and providers and tried to understand how well we were communicating and the extent of miscommunication, and to think about ways to address that. One of the situations filmed was me having a regular session with a patient who was a young woman on dialysis, where we were catching up and discussing some critical issues about her health. She had been coming to the emergency department at Royal Darwin frequently with severe fluid overload. When your kidneys fail, you stop passing urine, and if you drink too much water and other fluids, you'll overload your heart, be unable to breathe, and unless you urgently have dialysis, it will kill you. So this was the focus of our session. The way we did this research was they filmed the session. They immediately talked with me in English and this patient in her Aboriginal language about what we were communicating about, how well did we think the communication, what had happened, and then iteratively they would come back and show you the film and tell you what the other person said and try to deeply understand the effectiveness of communication. I came out and said, we've solved this problem. I'm a wonderful communicator. We talked about that she was drinking too much and that this was causing terrible problems to her health. She showed me how much she drinks, etc., and it'll be fine. I've solved this. Through the research, what became obvious, there were many things that became obvious to me, but in this particular issue, this patient was telling me how much Coca-Cola she drank as so I'll just focus on that particular issue. She had diabetes and knew she shouldn't drink sweet, carbonated drinks, and was limiting that intake. But at the same time, she was drinking 8 glasses of water a day because Kidney Health Australia and others tell you that helps protect your kidneys. Fascinating because she was not being non-compliant. She was doing something that she thought would protect her health from a message from, a quite, well-trusted NGO. we had failed, I had totally failed to understand, and she would have gone and been in the emergency department again 2 days later. But it's built on, that's a particular issue, but built on much deeper things of me not understanding in my position of power and dominance in that relationship, that to avoid conflict, she would say, yo, yo, which I thought was yes, yes, but was in fact an attempt to diffuse the conflict of that bloody doctor keeping on hammering me about these things that I'm not being able to communicate to him what I'm actually doing, etc. And so a deeper occurrence of miscommunication. So what did we find overall? Miscommunication was everywhere. That neither the doctors, nurses, educators, nor often patients and their family members were aware that it was occurring, and that it was about the most fundamental issues. There was a young man who we filmed in Community who'd been in hospital for 6 weeks, where he started dialysis. He was acutely ill, needed to come in urgently, got a bit better, went out to Community and was going to have ongoing education about kidney disease and the need to go back on treatment in a few months. He and his family thought his 6-week admission to hospital had cured him. So despite being in hospital for 6 weeks, having dialysis through a plastic tube in his neck, having an operation to create a fistula so he could go on permanent dialysis, they thought this meant we'd cured his kidney disease. So again, incredibly fundamental miscommunication. 20 years ago, surely it's changed, you'll tell me. 5 to 6 years later, we did the impact study, working with Indigenous patients, non-Indigenous and health providers across the country, interviewed almost 150 Aboriginal patients in depth about their experiences of living with kidney disease. Here, people talked about a whole array of deep issues, but I think particularly challenges is in accessing information that they needed to empower them to be able to make decisions about their treatment, their life, and that would impact on their well-being. And some, I think, quite profound statement about difficulties in communicating and getting access to the information that people needed. One thing when I talk to kidney specialists in my community is I think we too often, and this is perhaps yet another deeper issue about non-Indigenous health providers for Aboriginal people or in the cross-cultural setting, we make assumptions based on stereotypes of what we consider to be the views of patients, and at times I'll also talk about what we consider to be outcomes of healthcare delivery that need to be challenged. As part of that impact study, we wanted to look at why Aboriginal people had poor access to transplantation. And this will come out again in some later qualitative research. Aboriginal people want to get home, and for them the two pathways to get home are dialysis on community or transplantation. So these are ways in which they see as an opportunity to get home. But we assume and often talk about that Aboriginal people don't want transplants, that they're afraid about the medication burden, that there might be cultural factors that mean they're not happy about getting someone else's kidney in their body. But that's done in the basis of little knowledge about their actual views or understanding. So as part of that study, we tried to explore this in depth. And these 150 almost patients, I know numbers are not important in qualitative research, and I can, but this was at the time 1 in 4 Aboriginal dialysis patients around the country. They were strongly interested in transplantation. There were incredible challenges, some of which I'm already touched on, about becoming informed and communicating. They talked about the importance of family and supporting decision making. And they did talk about how they negotiated cultural sensitivities in a very important way. So as part of the research, the vast majority of people who gave a view expressed strong and definite interest in transplantation as a treatment option, because, as I said, they saw it as a way of making their life more normal and potentially getting home. They wanted to go home. They'd love to get off this machine. I can't go home, I'm missing my friends and family. There were only a small number of patients not currently interested, and 4 who were opposed to having a transplant, and 4 of the 132 odd who had a functioning transplant. But again, becoming informed about treatment options was fundamentally important. No idea, to tell you the truth. I don't even know what transplant they're talking about, said someone. I think a plaintive and fundamentally important quote there. I'd like to be spoken to clearly in an understandable way by doctors who like Aboriginal people. Confronting quote from that patient. The role of the family was critically important, so people talked about their family, and that's often obviously not our notion of a nuclear family, but extended family, being involved in decision making. But interesting that, and I'll bring this out in the next slide, that the way that individual experienced health was often the most fundamentally critical issue, and I'll explain why that was. But some people talked about other people who obviously have good kidneys. For them, it's not a life and death question whether or not you should have a transplant, and they talked very much about that. I'm keen to have it. I'm excited to have it. And that's where that cultural sensitivity issue also came through, that people did talk about what might happen if you die with someone else's kidney. But there was that rubric that they should have the right to make decisions about their own health, even acknowledging that there were other competing issues that came out clearly. I have to get a kidney from someone else. That's my decision. It's my body and I want to go ahead. I'm choosing my own choice. You know, that's my identity. So I think what's crucial about that work was still people talk about assumptions that Aboriginal people don't want transplants, that there are cultural issues that get in the way, and that they're not interested. And I think we have to put that to bed, that this research with Aboriginal and Torres Strait Islander patients across the whole country gives a very clear, starkly different view. 5 years later again, we did the Central Australian Renal Study, and people from across Central Australian region talked about the impact of moving away for dialysis. You know, a total despair, this senior community member talked about. In that case, I think, where someone had to go to Adelaide for ongoing treatment. And last year, for the first time, isn't it ironic? So each year we have our annual scientific meeting of the Australian New Zealand Society of Nephrology. We often present research about Indigenous health. Yet for the first time we had an Indigenous Patient Voices Symposium last year, and there's a report on our website where the people talked about what was important to them, solutions from their point of view, and were incredibly clear, passionate, and very powerful in putting what was important to them as issues. And I love this quote, you know, from someone talking about where they felt they were, the importance of their worldview, but also this, we've all now got to pack up and go up the, you know, to talk to the health minister, but a really important day where their solutions came to the forefront. And what were the key things they talked about? Going back to the title of my talk, we want to send to the government a message, we want to have our treatment on our own country. And I can say positively that I had the opportunity to chair the MBS Renal Clinical Task Force, which not only addressed Indigenous health but broad issues about MBS utilisation for people with kidney disease, but we were able to advocate and put in our report and have accepted by the MBS Task Force, and now hopefully going through government consideration, the introduction of a new item for very remote dialysis. Why is that important? Because it's a fundamental barrier to financial sustainability of delivery of dialysis services in very remote areas, that it falls between the cracks between the Commonwealth and state and territory governments, and that there are NGOs stepping in, like Purple House and others, but they raise their funds through philanthropy. So they're always struggling to have sufficient funds, and are others to make this model work. And again, I think it enshrines the notion of community-based, primary care-focused setting and engagement in this delivery model. Patients have talked very powerfully about a community-based Indigenous workforce, patient preceptors, healthcare navigators, coaches. And I think it's incumbent on us as people involved in delivering services and in research to partner with these organisations to fully develop, implement and evaluate these types of models so that we can make the case to health services why it will have an impact and why it's valuable and why these people should be salaried and supported and define a role like that. I want to finish by talking about transplantation. Again, I'm talking about this because patients see it as a way home and because the assumption is that there are worse outcomes for Aboriginal people. Again, an assumption that I think we need to do careful, targeted research to challenge. We know, here you might look at this, over 15 years, the number of Aboriginal people who've received transplants in Australia has what? Almost doubled at the same time as it's doubled for non-Indigenous Australians, but there's the numbers. So an Aboriginal person of the right age, sort of 18 to 55, 60 odd on dialysis, has less than probably about 1 in 5 to 1 in 6 chance of receiving a transplant as a non-Indigenous Australian. This is not improving. So we can see that it's Indigenous Australians, the access to transplant is worsening. This is not about living in rural or remote Australia. Non-Indigenous Australians in rural and remote Australia have equal access to transplantation as non-Indigenous Australians in urban areas, whereas for the Indigenous Australians you can see that that is critically important. The assumption that we need to challenge is whether it's beneficial and how our assumptions shape the way resources are allocated in health systems. So here, there is a notion that you need 80% survival for 5 years to be predicted to be considered appropriate for a transplant, and some leading kidney specialists, one appearing on 7:30 program on the ABC where this was debated, saying that Aboriginal people don't do well with transplant anyway, so they do better on dialysis. And here the most careful recent analysis that's going to be presented at the Transplant Society this year, we know for patients in general, a transplant leads to better quality of life, lower costs to the health system and for people to live longer. And I think we can put to bed that this is not the case for Indigenous Australians. Yes, the benefit may not be as maximal, and that's another discussion about equity versus utility, where I'm firmly on the equity side, and I think that's what the Australian population support. But we can put to bed this notion that Aboriginal people don't get clear benefit out of kidney transplantation. They do, and this is the best analysis and will be presented in the next month or two. So in conclusion, I think the burden of chronic disease necessitates a whole of system response, and if we don't do this, I think the gap in life expectancy will widen over the next generation. Prevention must address social determinants, but there are health system things that we need to do, working in partnership, particularly with primary care services and systems, about identification, early intervention, management to prevent progression towards dialysis. I think we need to continue to question and challenge our stereotypical assumptions about what people want for treatment, how and where we should deliver services, and how different patient groups benefit from treatment. And we must listen to and empower patient voices. Thank you.